started. Hello, everyone. Thank you for joining us tonight. My name is Matt Bobel, and I'm a surgery resident at the University of Minnesota. As many of you may be aware, George Floyd was murdered in Minneapolis 1 week ago. Our city and cities around the country and around the world are grieving for his life and protesting the perpetual injustices that Black people face on a daily basis. Our Global Surgery and Disparities program at the University of Minnesota wants to partner with one or more local organizations that support Black and other underserved communities in a surgical or medical capacity in our community. If you have any ideas, please send them to us either via my Twitter or my email, which I put in my name. And we would also encourage other GSSA chapters to consider similar partnerships with groups in your own community. Before we transition into tonight's event, I want to take a moment of silence for George and for every other victim of racism. Thank you for your support in that moment of silence. Tonight, we're delighted to co-host this event with the National GSSA team. We will learn about surgical non-governmental organizations, or NGOs, and how they have been affected by the COVID-19 pandemic. Surgical NGOs provide a key function around the world, offering care to patients who otherwise cannot access or afford care at their local hospital. According to a research letter published last month in JAMA Surgery by Kudsk-Iversen et al., there are roughly 375 surgical NGOs around the world. After collecting their data, the authors estimated that surgical NGOs perform around 2.9 million operations a year. However, the authors were not able to obtain conclusive data from almost 2/3 of the surgical NGOs, which means the actual annual operative contribution of surgical NGOs is probably much higher. Now, what if those operations never happened? The COVID-19 pandemic has all but halted the operations that these organizations provide. It would be challenging to try to describe the multitude of ways that COVID-19 could affect all these different organizations. For that reason, we asked Dr. Merlin Antúnez to talk about his experiences in Honduras as the medical director for One World Surgery and the Holy Family Surgery Center. Dr. Antúnez completed medical school and orthopedic surgery residency at National University of Honduras. He will briefly describe his path to becoming an orthopedic surgeon and give a brief history of the Holy Family Surgery Center and One World Surgery. He will then explain how COVID-19 has affected Honduras and One World Surgery. He will describe some of the factors that will influence One World Surgery's ability to return to offering their patients surgery. We will end the night with a question and answer session. I asked Dr. Erin Burke to join us for the Q&A portion. Dr. Burke completed her general surgery residency at the University of Minnesota. During her residency, she traveled to One World Surgery many times, which fostered her desire to include global surgery as part of her career. Since completing residency, Dr. Burke completed a surgical oncology fellowship at Moffitt Cancer Center in Florida and is now a surgical oncologist at the University of Kentucky. This past February, Dr. Burke completed her first surgical brigade at One World Surgery as an attending. She will be able to offer perspectives on what it is like to participate in a surgical brigade at a surgical NGO as both a resident trainee and as an attending. One final note before I turn it over to Dr. Antúnez. If you have any questions during tonight's session, please send it to us in the chat. We will hold all questions until the Q&A portion. And with that, I give you Dr. Merlin Antúnez.
Well, good evening, everybody. My name is Merlin Antúnez. I'm delighted to be here with you and join you. I am Honduran 100%, like I like to say. And if you see our flag, Honduras has 5 stars in the center, so that's why I say that Honduras is a 5-star country. I am very honored to have been invited for this event, and I was just recently telling Dr. Bobel, that my prayers are with you and all the protesters in the States by this time. I understand that the United States is not just that. I have seen and perhaps met some of the most beautiful people in my life, and might be a coincidence or not, but a lot of those come from Minnesota. So I understand that you guys are beautiful people, and I'm not convinced that what I see in the street or in the news is not, there's no need to solve it, but I also understand that there's way more and more beauty behind those. So I wish you guys the best, and I'll keep you guys in my prayers. So One World Soldiery is the name of the organization that I run on site in Honduras. And I have been the medical director for the last 6.5 years. And I'm an orthopedic surgeon per training. And I'm just going to say a little bit about my story. So if you can move to the next slide. So I come from a very poor area in Honduras, is like Northeast, and part of the reason that I had to grow up in an orphanage is that my parents divorced when I was around 6, and my other brothers were 5 and 2, and I lived in a very poor neighborhood, and my father had Parkinson's disease, and we couldn't. He couldn't provide for us, and so he had to give us to an orphanage, and we were in this orphanage run by the government for 9 months, and then they were looking for other places for us to go. And then if you can move the other slide. This man over there that is from Arizona, Father William Watson, had founded an orphanage in Mexico like 30 years ago, before my parents got divorced, and they were looking for new kids to come to a new home that they were building in Honduras. And so my 2 brothers and another friend of mine that live in that orphanage run by the government were the very first 4 pequeños. Pequeños because it is our little brothers and sisters, and pequeños is the translation for little. The other person that you see there is Father Rick. He has devoted his life to serving others. He was a priest when he came to Honduras, maybe in his early 30s, and then he went back to medical school and became a physician as well. And he's currently living in Haiti. And so there are 9 different homes that were founded by this man that you see there in front, and this other man that you see there on the other side, he has been dedicated his life since he was became a volunteer to Nuestros Pequeños Hermanos. By the way, I named my last son William after these 2 guys. So his name is William Rick because of these 2 priests, and I hope that he can be a saint to these guys, and I have no pressure whatsoever. The next one too. The next slide. Okay. So when I was 7, I had never been in school, and my parents only were perhaps done with 3rd and maybe 6th grade of elementary school. But when I was 7 and I came to MPH, I kind of realized, that I had to decide what I wanted to do in life. And I think that there's a time in life when you need to stop and say, what do I want to do with my life? And for me, that was 7 years old. So I knew the reason why my parents got divorced and why I was living in an orphanage. And I thought that being a doctor will help me. And I said, well, like if I could be a doctor, maybe I can heal my father and my family can come back together. And so I pursued that goal. I was very interested in surgery very early. I love wounds. I love dissections. My friends in the orphanage will come to me and say, there is a dead animal here. Do you want to see how it looks like, or things like that? So I wanted to be a plastic surgeon in the very beginning. And I was never discouraged, even though it was going to take a long, long time. But it was in December 2008 that I graduated as a general physician. And the one that you see there is one of my brothers that came to see me for graduation. And I worked 2 years as a general physician. And one where surgery was starting in Honduras. And I offered to do the follow-up as a general physician. And then I met the co-founder, Peter Daly, who happens to come from Minnesota. And he came over here in the very beginning. It was like, you say, we're going to have a brigade. We call the mission trips over here. And so we have a brigade, and then you have like 200 people who show up at the main gate. And then you have to screen out those 200 people. And then you'll decide which ones you want to do surgery on based on the capability that you have and the supplies that you have. And so I was doing the follow-up for those patients. And after 2 years, I wanted to go back to residency. I told Dr. Daly that I wanted to become an orthopedic surgeon, and I had quit my idea of being a plastic surgeon and a general surgeon. But it was just the inspiration. This guy is amazing. He treated the patients with a lot of respect and dignity. And I would say that the same way that anybody in Minnesota, I mean, he was being paid to see those guys over there, and he was coming and dedicating the same time and the same effort for the poor patients in Honduras with just a thank you or smile on their faces for a return. So I said, like, I want to be like that guy. So if you can put the next slide. So in 2013, I became a general orthopedic, and it's our training is only 3 years. It's very intensive, but it's only like trauma. There's no like sports. There's no total joints. There is no upper extremity surgery, or just like foot and ankle, things like that. So I was invited to join the surgery center and became the medical director of that place. So if you can put the next slide. The story of the surgery center begins with this little girl named Angela that actually is now in Minnesota, taking care of or helping Lulu that you see there in the picture with her grandchildren. So Angela, you can see the deformities on her knees, and she was not able to walk anymore. And so Dr. Daly and Lulu, who is a nurse, had been helping and supporting MPH many years, but they had never been down in Honduras. So when they came, they were asked to see this little girl and see how they could help. And so if you can show the next one, the next slide. Oh, I thought I had another one, but okay. So they had to take her to the Minnesota because the first surgery, or the first little surgeries that Dr. Daly was able to do in Honduras were done on a trailer. That this trailer had in principle the task of going town per town in Honduras, stay there for like the amount of time that they needed to do a lot of like bumps and little hernias and things in those towns, and then they were moving, but it was based or it was funded by the government actually. So when that trailer was just about to fall apart and things, so they kind of created a station for this trailer to remain within the property of Nuestros Pequeños Hermanos, the home for the children. And they were not able to do Angela's surgery over there, so they took them to the States. Took her to the States, and then she was there for a year or so, and then she came back, and she was able to walk, and she had straight legs, and had a different life. And so they said, like, we can replicate this in Honduras at a bigger scale, and we want to pursue a dream of creating something little where we could do surgery every once in a while. And so that's how the idea was born. And when I came to and became the medical director, it was just like the picture that you see everybody in scrubs. Half of those were volunteers, and one of them came from University of Minnesota, and the others, you know, like the two of them grew up at the home, and then the others were employees from the city, including me, that grew up in the home. So it was just us, and it was just doing, you know, surgeries. In the very beginning, it was just like 2 or 3 missions in a year, and so you had a whole surgery center that was just sleeping there, and that you had to clean every time. But when this group was there, then it was the very beginning, back in October 2013, when I was still in residency, that we started doing surgeries 3 days or 2 days of the week, and then having clinic on the rest of the days, and seeing very little patients. But if you see the other side, that's a picture of the group that is currently down here in 2019. A lot of those, several of those people that you see that grew up at the home, some of those are volunteers that come from different areas in the United States. And then some others are just are people out of Honduras that they're hired, and they're fully committed to pursue the mission of giving the best care possible for the patients. If you can advance this slide. So I really like your group. I love it. I think that you have, in principle, something the world is looking for. And if you can see, global surgery can be applied or can be performed in every place in the world. I mean, there's a lot of like places that need it, because either they're going to a crisis, or there's a disaster, or there are just people that do not have access to this type of care. And most of the world's efforts, the World Health Organization, for example, is based on more clinical care, which is good. I mean, I won't deny that, but there's still a lot of limitation that could be addressed surgically. The next one, please. So Paul Farmer is someone that I really admired, and I have read some of his books. And you know, in one of his articles, that you can see the reference down, he says, you know, the amount of people that is lacking surgeries in the world is huge. And a lot of that population is also poor people, and our country is not the exception. And he calls surgery the neglected stepchild of global public health. So that's why I think that this association for global surgery and create an impact from the time that you become a student, I think it is really appreciated for, you know, everybody that is in this field. If you can go to the other one. So you know, a lot of the times you wonder why people don't want to, you know, it is easier to do primary care. It is easier to do some social work when you come, building latrines or building houses and things, and you see right away what you're doing. But to be able to perform surgeries in a setting, you require some tools, you require implants, and there are some that are more challenging than others. But you know, if the World Health Organization is just going to focus on infectious diseases, or we're not going to consider that surgery is part of the public health, or maybe, you know, surgeons do not advocate for it, or it's too complex, then a lot of people suffer. And you will see, for example, these pictures from a patient that we see here in Honduras, and that had that broken femur for a little bit of over 6 months. He was just on a cast because he couldn't buy the implant that he needed to have for surgery. The next one, please. So, I mean, if you see trauma deaths are, you know, there are more deaths if you combine the deaths that are related to tuberculosis, malaria, and HIV. And I'm not saying that it is not important to tackle those because those diseases will live like in some of those areas, and it will be so hard to eradicate those. But trauma has a big impact on healthy people. And so I think that we need to be paying attention, and you guys are doing that by having this group. And if you see the amount of fractures that we have in the world, at least the ones that are being counted, is very close to 3 million people that have a broken femur, just as an example, and you're not including all the other needs. The other one. Okay, so as a consequence, you will see that you know, there will be significant disability. Like this person, for example, could have been a housewife that had a non-union on the wrist or the forearm for 14 years before she was able to get surgery through a medical mission. And a minor problem becomes a big issue. For example, someone that has a club foot, something that you can address easily when they're newborns, and you can just put a cast on. Then, you know, they grow up with that, and then you need to tackle those when they're 15 or 20 or 30. And so it becomes a big challenge to treat all these diseases if you just let something little, you know, you have a little hernia, but then it becomes a huge hernia, and, you know, you need to, it requires more time. It requires perhaps not do it laparoscopically, but you need to do open, and the recovery takes longer. So little things or easy things to address become very complex. Next one, please. So I love this picture because I think that this is the way that I imagine our health system in Honduras. You know, it's like just like this. We have very little, and, you know, with the minimal, I would say, pandemic, then everything tumbles. And in this case, I was, you know, with the pandemic that we're currently facing now, we still have that need, and plus we put more load on the system, and we're not doing well on a daily basis, and then we have something like this. And so it's very complex. It's very complex. So if you can put the next slide. So, you know, if we see some of the data on our site, because there's a lot going on global missions that want to do surgery. A lot of the times you go to a place, and then you need to use a facility that belongs to the government, and then you need to rely a lot on the quality standards that they have over there in those settings. And then you need a lot of tools, and you're used to certain different tools and several in different settings and different standards, and then you come and you get to a different you get to a different reality, to be honest. And so, you know, there's a lot of encounter, but the one thing that we had as a challenge beginning our mission here is to create a different reputation, because everybody's saying, okay, they come and bring students, and then they practice on us, and then they leave, and then we have a complication, and we need to address this complication. So a lot of the, in the very beginning, it was a lot of talking and getting involved with the, going to the rounds of the National Hospital and talking to them, telling them, we're not going to compete with you. We want to tackle the poor, and this is what we want to do. So when we see now that we have a better setting, because we do have our own facility, we know when to start. We have our own tools, we have our own implants, we have our own drapes and things. So we can kind of decide if we want to focus on just one area or different areas, or if we want to, if we want, what are quality standards and what we want to do. But if we see this now that we're paying attention to what the patients are, what is happening to the patients, we see that patients have to wait almost 5 years before they get an elective surgery. 5 years. And then some of those will, have will be totally disabled. And perhaps those ones that are disabled are young adults that could be the ones that are providing for the family. And so part of the impact that can be created through global surgery has to do with that. That you can come and do something that for the patient is so hard and seems to be impossible, and then they're back to work. And you can see some of the numbers below, because our patients said, like 80%, for example, they say that they can foresee a better future for them and their family now that they have recovered. And then if you see the other one, for example, 87% said that now they live a full and productive life. 87% of the patients that we do surgery. And there will be some, sometimes there could be some bias too, because maybe they do not have an employment, but they are the ones that are cooking and doing the homework and being housewife, and that's part of the activities that they usually do. So our goal has been to tackle the poorest of the poor. And so we have created through the years some type of combination of patients that classification that will be based on the doctor's classification, meaning urgency 1 through 4. And then the other one will be a classification that will be based on a social worker, an interview with a social worker. So if you can see there, we have like almost 90% of the population either in A's and B's, and that are 1s and 2s. So the most urgent and the poorest. The percentage that is missing there, we just lost because we couldn't get a hold of the patients, and or we either didn't register that. But that is what we are trying to do as a mission, and the impact that we want to create in our community. If you want to go to the next one. Okay, so our cornerstone are, running medical missions in the world, creating an impact in the community and working alongside with them. And then we also have education. So we have been trying to do some research, and there's a lot to do, especially in a country like Honduras, where, there's not a lot of publications or research being done other than the National Hospital. We want to perform or do more than that, and that's what we have been doing. A lot of the research that we do is just to understand what we're doing and the impact that we're doing, but we also want to have the opportunity to do any publications. So we're trying to see where the patients are coming from, what is the impact that we're creating in their families? Are they able to go back to work? We want to be tracking a complication rate, and we want to have the same standards that you have in the States. If you're trying to have less than 1% infection rate, well, we want to try to target that too. And we do have the setting. We're trying to have someone that is actually making phone calls and making sure that patients are coming to our place. If they have any wound problem, we want to know, and we want to keep track of that, and we want to know what the complications are. If we have to transfer a patient to the city because we didn't, couldn't void after surgery or something, and we were not able to address it in our place, then we want to do that too over there. We're trying to keep up or keep track of all those variants so that we can improve upon the ones that we have. Then we depend a lot on volunteers to do this, and we have a lot of smart young adults that come after college and they want to spend a year with us, 13 months. And that is how we can do this because it's really challenging for a non-for-profit to hire someone for a different task. And so on the other side, there's a really neat opportunity for young pre-med students or people that just want to take a pause in their lives and see what they want to do in the future. If you want to go to the next one. Then, this is more trying to compare us to when we have missions, because, and I would say, why is it important to have missions come to a place or to a setting? You can maximize the use of the ORs. You can see a lot of patients. You can see or do more surgeries. And this is an interpretation of what happens. So for example, if you see on the left side of the screen, that's when we have mission groups. So we're kind of squeezing all the time in the OR. And then on the other side, for example, we're not doing it, but still the green bar, you can see that is high because our team is also doing the follow-up for the patients that are having surgeries when we have mission groups. So for example, when Dr. Tuttle comes, with his group, we will give him feedback on what is going on with the path reports, with the wounds of the patients that he did surgery on, a breast cancer patient, for example. Or we want to keep track of those patients too. And so the clinical portion is still high, but I'm the only surgeon doing surgery. So we're trying to see what would be the best ways to maximize the use of the surgery center, because I'm just doing surgery. This is 2019, so I was just doing surgery 2 or 3 times in the week. And a lot of the times it has to do with, complex cases that take many hours. So we were trying to see how long it takes for our team to do some surgeries when we have no mission groups, and what it takes when we have mission groups, and compare the data to the ones in the States. And I mean, this is the important part of having missions or having global surgery available through groups like yours in different sites, because the impact is huge, and you can tell right away over there. And bring in the expertise, bring in education, bring in experience, bring in good habits for surgery care. It's amazing. And when I say good habits, it's like comes from pre-op, comes to PACU nurses, comes to OR nurses, to every part that will make a whole mission group give or develop or be able to accomplish this surgery. So I think that if we didn't have that, we wouldn't be able to do more. At the very beginning, we were just having 2 or 3 mission groups in the year. Now we're having 30. So the impact is a lot bigger too. And then you can give more consistency too for patients that need a second stage or have addressed some complications. If you have the other one. So what is next? I mean, we're trying to continue doing, keeping track of the variances. We want to be more efficient. We're thinking of publishing publishing some topics. In this case, for example, osteomyelitis is one of my favorites. Not that we have a lot of infection in our place, because our infection rate is less than 1%, but we have a lot of infection that comes from the national cities. And so at this time, we have a good relationship with the national system in Honduras. Such a good relationship that when we have a mission and we tell them, they will refer patients to us, patients that are complex, patients that do not have an opportunity over there because they need to wait long. And so we're trying to do our best to work with them. We're in talks of like having even residents come from our national system, come to our place and spend some time with you guys when you guys come. Because we understand that culture of information and experiences exchange, will give us a solution of, like, we understand your standards, we understand how you do it in the States, but how do you guys do it when you have nothing or when you have less? And that experience is good, especially because if we want to minimize the cost of global surgery care, there will be some things that will work for Honduras. There will be some things that will work for other countries. Yes, Peter. Yes, sorry. This is my son. I'm sorry. So I think that it is good. I will invite you guys to read that article that we published in Elsevier. If you want to see what the impact is, but we were trying to have this type of measures and see what was the impact that we created in the life of the patients that we serve. And if you want to go to the next one. And if, like right now, for example, going back to the main topic that is COVID-19, I mean, this is the way that Honduras looks like. And we seem to have cases everywhere in the country, having, and we actually stopped doing what we usually do. As a mission, we were terribly affected because we haven't been able to even, be able to do, I don't know, maybe close to 10% or less than 10% of what we do. We usually see 40 to 50 patients a day. We usually have or host a mission every week, and we've been able to do that. We have stopped completely that one day of the week, and those are, for wound care or removing cast or removing pins or things like that, or people that needed to have some advice. In this case, we were doing nothing for the last almost 75 days since we had a lockdown in the country. And so as of today, we had 5,346 cases that were positive out of like almost 20,000 tests that were done in the country. And we still think that that's enough. We still think that there's bias information given to us in conference. We have 117 deaths, and that's like close to % of working in this, there are those taking captivity, like we're through this every.
Dr. Antúnez, I think we might have lost you for the moment. I think he's going to try to sign back on. In case you didn't see, Evan was able to put the link to what Dr. Antúnez was talking about, the article, in the chat. And he's WhatsApping me, so just a second. While we are waiting for him to respond, does anyone have any questions so far? Dr. Burke was able to join us after clinic. And Dr. Todd Tuttle has also joined our panel. He is the one who kind of established the relationship with One World Surgery for the University of Minnesota and has led numerous trips down to One World Surgery over the past 10 years or so.
Hi there, sorry for my late arrival. Good to be on. Hopefully we'll get Dr. Antúnez back here shortly.
Dr. Burke, do you want to just spend a couple minutes talking about how your experience this past February as an attending doing some global surgery was different than your experiences when you were a resident, and like what that felt like and things like that?
Sure. So I was introduced to this program through Dr. Tuttle, as Dr. Bobel was speaking about, and first introduced as a resident. And this year was my first trip down as an attending in February, before things really started to kind of spin out of control as far as the COVID-19 situation. It was a really neat transition. I actually think there are quite a few similarities to the transition there as there is in the States, going from fellowship or residency to being an attending. I think you're learning a system each time you're making a transition like that, and it was no different for us and for me in Honduras. And so it was a really interesting to see the parallel between the two, and I think that speaks to the kind of work that's being done there. It is a system. It has been set up to be successful in the way that we triage patients, get them to surgery, and then follow them up. And I think that was something that I saw very clearly as I tried to transition from a resident there to an attending surgeon there. And so for me, I thought that was a really neat parallel. I think it was, when I was a resident, it was incredibly educational. I felt like I had more ownership of my patients, not because the attendings weren't completely there, but because I just got to spend more time with them than I did as a resident that was trying to deal with paperwork and pages. And so then as an attending, I saw this and I felt like I had more ownership in allowing the residents to do that and have that feeling so that they can recharge and make it through the next anywhere from 5 to 7 years of training. And so for me, I really enjoyed that progression. I really think that it helped me get through training, and I think will help others get through training, and I hope to see that for them. And I know it recharged my batteries and just kind of going back to work. after that, especially given the past few months, how difficult it's been.
Great, thank you. And I see Dr. Antúnez is back, so we'll let him resume chatting about his presentation.
I'm sorry, I don't know what happened. There was just a glitch over there, but glad to be back. So I was telling you that we don't think that the government is being accurate, and we don't know if this is on purpose or not. But this matters for the time that you want to start, because we don't want our employees or coworkers to be exposed to someone that is sick, and we have been working over the past few weeks on protocols that will tell us what to do next. But if you can see that, most of the patients that we see are men compared to women. There's 63% of those is in Cortez, where you see the bigger star. And that's where we have more of the deaths as well. There is like 60% of those deaths are there. And then the other 20% is in Francisco Morazan, where that place is where we're close to. And over there, we have like 10% of those deaths from 217. But if we want to be responsible and we want to know what the next steps are, we need to be watching what the government is saying, and also talking to friends and doctors that work in the area, because you have a better sense. The government is trying to think about of like a smart reopening, and this week is supposed to be like kind of getting ready. Everybody should be getting ready for that. And this smart reopening is like based on 5 weeks that will be, like next week, for example, everybody will be allowed to go back to work, but in a 20% increase every week. So in 5 weeks, 100% of your capacity in a factory or whatever you are should be able to be. But if you can move to the next slide, please. If you see this curve, I mean, we were doing more strict decisions and having the lockdown and things when we started than now. I mean, the government is planning to open, and they don't show that the number of cases are decreasing. Everybody's complaining that, and this is a reality. I mean, in the States, you have, I don't know how long it will take for you, but I know that you guys have been working hard to get fast or quicker results. For us, the government was the only one doing the PCR test, and then they kind of allow some private laboratories to also do some other testing, and it will take 10 days for you to get a result, unless you are a politician or you have some connections. But it will take 10 days for anybody. And so in one of the hospitals, for example, that is the main hospital where COVID-19 patients are being seen as an adult patient, they will only take samples at 5 p.m. And if you come later, you don't get the test. And if the patient dies within that period of time before 5 p.m. and is taken away, then that patient is not going to get a test. And so we do have the feeling that we see that there are more patients every time. And now the government is thinking about this smart reopening of the country and going by 20% each week. And so far, right now, for example, we have like, if you can move to the next slide. We have like around 500 people hospitalized, and that's a lot for a country. And you know, we have like 25 people that are very sick and 50 people that are in ICU. Doctors that work in the main cities where you saw the stars, they said, you know, there's no more capacity. We have such a few ventilators when we have no COVID, and with COVID, we have nothing left. And that's why one of the doctors that I talked to before, you know, completing this presentation, he said, you know, like, I see every day 2 or 3 patients die in front of me because I don't even have a simple ambu bag or something that I can resuscitate them with. And so this will affect our mission if we want to bring new missions or host new missions, because we want to be responsible. We want you guys to be safe, and everybody wants to be safe, but we don't want to, you know, if we want to go, we're trying to plan on how long it will take us to go back to normality based on what the government is. And talking to my coworkers, we were saying that we need to be behind what the government is saying, and we can do like kind of trials, and we can divide our groups and try to find creative ways of being able to see patients. Like, we have no testing availability, and one PCR test will take 10 days before you get it, and then you will have to pay like around $200. And so if our patients don't even have for transportation to come to our place, we need to find ways to be creative and maybe ask them to quarantine at home, monitor them on a phone call, and ask for coughing, for fever, or any exposure to someone that might have been diagnosed with COVID-19 before we actually can see them. And then from the 40 to 50 patients that we see every day, perhaps we can see 10 in a safety way. And so we will have to be paying attention to that. If you can see there too, you know, our population is young in Honduras. We have maybe 40% of the population is younger than 18. But we have seen doctors, we have seen nurses, we have seen microbiologists that have died because of COVID-19. The government has had approved a lot of money, but it's being given to I don't know who. Most of the doctors that are working in the different hospitals, they say that they don't have the support that it requires. And even if the government is trying to give or planning to give, still, you know, like the PPE is so expensive. It's so expensive, and you need to kind of learn how to reuse, and things that cannot be reused, then you just need to have, again, and I mean, we have improvised, and I saw the news, and I don't know that this is the way that it goes, but in the States, some nurses improvise too, using like some plastic bags when you guys were not ready for this. And so if you could see something like that in the United States, imagine what you can see in Honduras so far. If you could go to the next slide, please. So we are not doing any missions, or we haven't hosted any missions in Dominican Republic, and Dominican Republic has a similar condition than Honduras, but they have way more cases. Perhaps they have more testing available too, but we're trying to on-site stage cautious return, and we want to maximize the use, and we're trying to tell some of our personnel that don't need to be in the facility to work. You know, maybe they have their computer at home, and maybe they can do phone calls from home. They don't need to be in our facility, so that we can maximize the space to see more patients. Trying to divide ourselves in groups so that not everybody is at the same time over there. Trying to have short days so that we don't need to be taking our gear out, you know, like the mask and things, that we go there a little later and maybe come a little earlier at home. And then everybody needs to follow some instructions at home, like how to, you know, take away their clothes, take off their clothes, and take a shower, and go and try to treat their houses. as an OR, that they need to be sterile when they come in. Then based on the missions, we have a whole protocol, that has changed every week. It changes, but we have like 4 different stages, and we have in these stages different triggers for to move to the next stage. But one of those, for example, is that we need to see what are the warnings of the United States. We want to see that there's some availability for airplanes to come to our country. We want to know that getting some testing from Honduras, either asking our volunteers to get some testing before they come. We want to talk to them and say, guys, do you agree that you want to come, even though we're going to move to maybe hosting a small group, around 15, and then maybe later on hosting like 30 or so, and then maybe 50, and then later on the first stage, when there's no restriction and no mask that we're asking everybody to have at all times, we can host everybody. Our mission allows surgeons to come with their spouses and with their children and spend time together and bring medical students or perhaps students that are interested in doing. And so by the meantime, we will restrict it. The behavior of the pandemic, we're going to decide if we want to do more. So by the meantime, if I had to say, TR is not doing anything. Honduras is just doing like very little, and the government is encouraging to reopen this smart reopening, but we're going to be really cautious because we have no testing availability. We understand what is going on in the city. And on the other side, remember that we are in the home of nuestros pequeños hermanos. And so we are trying to help with them to monitor their personnel. So in order to protect the whole population, because there are 500 kids that live in the home, our personnel is using Moscati, that some of you know, which is like a kind of conference center and hotel, to ask the employees, like the caregivers and some of the teachers that are able to come, to quarantine there for 10 days and then quarantine at home for 5 days. And then we're monitoring them on the phone, making sure that they're not having any symptoms. And so, by the meantime, we will have to kind of negotiate with NPH about like when to host, how many we can host, when we have no capability of doing any testing. So it's hard, but we have a great team that works in the States trying to fundraise for us, even though most of the activities are being canceled. And then on the other side, having a whole team over here in Honduras that is fully committed but cannot do what they love doing, and still, keeping everybody with their salaries is expensive for a non-for-profit. So, but so far, I think that One Researcher has been fully committed to not do any changes, except that for us, we were not able to hire new personnel that we were planning to have for this year. So far, we were able to do around 500 surgeries just until the beginning of March, and the complication rate to that level was just like less than 1% too. And so we were so excited. We hosted the first conference with medical conference, and we had as a topic breast cancer, and that was really fantastic. And we were hoping for something like this to to be happening, you know, or along the year, but then we had COVID-19 and then we had to stop. So, I mean, I'll be very glad to answer questions if there are any from the audience. That's my family, and that's the entrance for the conference center and where missioners stay. And my brother was the one that built that place, the one that you saw there in the picture in the very beginning. And he says that all the missioners that come are angels, and that's why he put those wings in the very entrance.
Thank you very much, Dr. Antúnez. I'm going to stop sharing my screen. I know a few of you already submitted some questions for us to chat about. So we'll transition into that session. Evan Keel, he is also on our panel. He's the president of our University of Minnesota GSSA chapter. So he'll start us off with some of the questions that have been submitted ahead of time. And if you didn't send questions ahead of time and have something, definitely send us something in the chat for either Dr. Antúnez or Dr. Burke. And if you do have to leave, I know it's a little after 7:30, so that's totally okay. The recording of this will be posted later. But otherwise, go ahead, Evan.
Yeah, hi everybody. Yeah, my name's Evan. I'm a rising third year here at University of Minnesota. One of our most repeated questions, which maybe we can start with, was how would you go about setting up a NGO like your own in someone's hometown or in their home country?
You know, I think that you will have to kind of see what you envision. What do you want to do? But there is I want to paraphrase something that Ron, the Minister of Health, said. You know, you kind of need a foreign force, you know, like you guys in the States, for example. Then you need some local team, and that local team be working together in order to continue with the mission on the site. And then if you want to, it depends on what you want to do, especially if it is surgery. You can, the easiest way will be to join one of the main hospitals or one of the hospitals in the places where you want to go and try to create some relationship over there. But you need to understand that, I'm sad to say this, but if you bring equipment and you leave it there, perhaps it's not going to be there next time you come. If you want to have your own facility, it's a little harder. It takes permanent people there taking care of the equipment or doing the follow-up of the patients that you do surgery. So it depends. I mean, I know that there are some other missions that, you know, in like operation, small operation, they do work and they do they do have a big impact in the community, but they have nothing to do with facility or running any facility, and they just work with volunteers. And then where are you going to get the funds? How big do you see yourself growing? So it's a little challenging, but you need to create some type of partnership, I think, because when you create partnership, when you create education exchange, and then it is easier to have success.
Great, thank you. Yeah, and just as a couple follow-up questions to that, I think it'd be helpful if you gave some context about the length that it took to set up One World Surgery, and then also maybe any resistance that you met in that, forming maybe perhaps partnerships with institutions or governments, as you mentioned.
Well, you know, in the very beginning, it was just like type of building the facility and type of, you know, you have to be thinking of like, you know, you envision something small, like Dr. Daly and Lulu were saying, you know, we just want to have a little room. We went to do surgery. And then people thought that's a cool idea when you make it a little bigger and I contribute with this. So it took like from 2003 till 2009 to have the first patient. And the first patient, you know, was not a big surgery. It was just like a little worm in the skull, but that seemed like to have had like brain surgery or something. So a few years to that, then it was every time it was like kind of building upon the first year. There were done like 40 surgeries in the whole year in 2009. And then, maybe a couple of years later, it was like 200. And then in year 2020 or 2019, we did 1,400. So, and this is where other groups or partnerships are good, because we were lucky to have some other organizations or enterprises that joined the effort. I don't know if you guys are familiar with surgical care affiliates. They have ambulatory surgery centers in the States, and it's like 230 surgery centers in the United States that they have kind of sponsor us, and they will bring volunteers. They can come in the missions, and that's how we were able to do this much. But in the very beginning, what was key was Summit Orthopedics that is actually in St. Paul. And this group works in different areas. I know some of those doctors work at the U.S. like kind of friends, kind of family members that were coming for the very first couple of years. So year 2009, when we had 40 patients in the whole year, but then we had 1,400 last year. Every time you saw that there was double.
That's great. Yeah, I love how you mentioned that it's 2003 to 2009. It's quite a long time before you had a singular patient, and so I think that's encouraging to people that are interested in the audience and hopefully listening online later, that this might be an experience that's not just a couple of years or even 7 years it might take to really start seeing partnerships and seeing patients coming and seeing people getting bought on board to the vision that maybe you have or had 7 or 8 years ago. So yeah, I think does have importance.
Yeah, but like now, for example, we have been trying to do the same and replicate the same in DR, but then you need to fundraise, and you know how big you want it. And so this time it's like, okay, so we need to fundraise this amount of money before we actually commit to that. And by the way, we were ready to start the construction over there, but COVID has stopped us. But it is easier when you have like a pattern that you want to just copy paste. And then, but even though we do have closed, we almost have the whole amount of money that we need for that. But still, it will take 2 years before it is actually being built and we do the first surgery. You shouldn't be discouraged.
Yeah, that's great. Maybe this would be an easy transition to discussing more about fundraising and how you fund One World Surgery.
So we do have a great team in the States, and they try to do events. I was there last year in St. Paul, or actually that was Minneapolis. But there are events in different places. There are activities like Giving Tuesdays, or there are some other activities where just donors will contribute. Then with the doctors that come, or visitors that we host, they also contribute. A lot of the times, for example, what will happen is, for example, the surgeon will come and we'll pay for the flights, and they will donate us $1,000, and that $1,000 is supposed to be covering a footprint of hosting and food and transportation and security, and then the rest is going to go to the patient care. So I think that besides like that footprint and the in the salary of the personnel and everything. I think that 15 to a little bit, maybe 16% will go to that. But then the 84% is going to the patient himself. And then we also accept in-kind donations. So doctors will advocate for that. You know, we have a doctor that will talk to the reps and say, you know, I'm going to this place. Do you want to give me some implants or some mesh or whatever the specialty is? And then we will get those in-kind donations, which is actually good because we can be able to do surgeries at a very low cost. In the very beginning, we had an average of like giving this high standard quality care to patients for $250. But we had a lot of volunteers. Then we had we grew, and then we were trying to we were hiring more people, and so but still, I mean, you can get a total joint for $1,000. Let's say, you know, like when you get the in-kind donation, when you get the surgeon to come here and does the surgery for free, I mean, $1,000. Where in the States do you get that like that? So.
Yeah, thank you for that. I think you again highlighted the importance of partnerships, right? It's both within the country, but also partnerships from without it. And I think that just continues to highlight the importance of us finding people as organizations like this are started to partner with. And yeah, I love how you've continued to mention that. We had one question just come in about how you find patients that require surgery. You mentioned that you might screen upwards of 200 people for a given trip. I just wondered if you could talk about where those patients are coming from, if there's some sort of list or a national like organization that helps organize that.
So through the, you know, in the very beginning, it was us going to the radio station or asking for permission in the boss and saying, you know, we want to put a sign there saying that we have a mission. And then all those 200 people will show up in a day. Later on, it was just spread of mouth, or how do you say that? It's just like, you know, some people would tell other people, word of mouth, you said. And so people will say that to everybody, but you saw we have 9.5 million people in Honduras, and people come from all over the country. Not for, and it will depend on the type of specialty, but for example, with Dr. Berg and Dr. Bobel, that came here with breast cancer missions. We also partner with other non-for-profit within the country that do a part of the process. You know, like they will diagnose and they will do some of the follow-up and do the clinical part, but they do not have a surgery center. So we do the surgery and then they can do the follow-up. And this is how it works. But it's word of mouth. We don't need to tell anybody now. And we do have, you know, I was just telling Dr. Bobel that we had like 2,000 people that we call during the pandemic saying, you know, we're closed. We want to know if you're interested in the surgery still. And it's like, you know, just 50 people say either no because they were feeling better or because they already had surgery or passed away for different reasons. So we don't need to tell anybody. We have a waiting list. We have their phone numbers, and then we call. We do see 40 people, 50 people a day, and during brigades or when we have missions, there are more. But it's sad to say that, you know, in the main gate where people have to go through, you see 30 people, 20 people every day that do not have an appointment, but they want to be seen. And most of those patients will have x-ray. Just before we had to close, you know, there was, we were able to do surgery on a man that had like 5 different fractures, and some of those malunited. And he had been in ICU for so long, and it's so hard because you will see people that, and I show you, I show you in the slide that people have to wait like an average of 4.4 years before they can actually get surgery. So we are now known, and we also tell, you know, the main hospitals if we're going to do they will even contact me, for example, because I was trained there, and they would say, when do you have a mission group that will do this type of surgery? And then they will refer the patients to us for that.
Great. Yeah, that's really helpful. Really succinct answer. I have one that was submitted prior to the talk, talking about advocacy and how you, as a physician and as a surgeon, ensure your patients receive the care that they deserve in your context and at One World Surgery.
I think that I have as a personal task to give the best of me to my patients and walk the extra mile for the patients that need it the most. And so I expect to have the same commitment of my team or my coworkers. And I will encourage my whole team to walk the extra mile for those patients. When I talk to my physician, the physicians that work with me, I tell them, make of this guy your best friend, because perhaps it's the most in need that we have seen in the day, or because they're the poorest one that we saw. So we are trying to have the same standards that you guys have in the States. We are trying to, it's so hard to decide on which patients you want to see, but we want to do surgery on those that need it the most. But if I dedicate like 99% of my practice to only one word surgery, and I enjoy it a lot because, as I was telling you, in my training it was only trauma. But then, I was thinking in my life, I want to go to the United States or to another country, and I want to do a fellowship. But then I got all these great surgeons that come from the different places in the States, and they stay there for a week. It's like having a little rotation every time. So, it's about empathy. It's about how much you enjoy it. It's about noticing that there's a huge difference in between using the right proper tools and using the block and vector drills, for example, that I used to be using in residency, because we didn't have, I'm fully committed to the mission, and I'm fully committed for the ones that need it the most.
That's great. We can tell that even through a video screen. We can tell your passion for your patients and for One World Surgery. We have one final question if nobody submits another one. But yeah, so how can we, with our local partnerships, or our global partnerships, excuse me, how can we be helping during this time where international travel is near zero?
I think that this is just temporary. Perhaps there's going to be a long pause, but as far as, you can spread the word, you can, try to talk to vendors if you have access to them. As far as you can advocate in some way, I think that you can do that. We're even planning on having, for example, for some of the patients, once we start going and we know that we have the setting, we want to have some telemedicine, for example, with maybe a physician on site, or we want to have in the future maybe some conferences where we can have like some of residents or national residents and exchange some talks with you. But in the meantime, I think that if you stay safe at home, I know that we're going to see each other sometime down here. But if you can just spread the word and find ways of how to connect with other members that would like to come, or try to read about how we work and how you want to join a mission group, for example. We do have the options of surgical mission groups and then primary care mission groups as well. They can be either joined to Honduras or to DR. So if you can do some of that, that would be good enough. But in the meantime, I mean, I would love to have you down here sometime soon, but there's some temporary limitations, I would say. But But this is once this is gone, I know that it's going to be different.
Great. Yeah, I might turn it back to Dr. Bobel if he has any final questions. Yeah, we appreciate your answering.
Thank you.
Thank you, Evan, and thank you, Dr. Antúnez. Thanks, Dr. Burke, for being here too. So I put in the chat box the link to the One World Surgery website. Definitely go check them out, see what they're about, and look into volunteering with them once we're able to travel again. You can also follow them on Twitter. I want to thank everyone for coming tonight. I do think it might be interesting in the future to have a session about transitioning from residency to attending SHIP and global surgery, and maybe Dr. Burke can join us again for that talk. This talk will be uploaded onto YouTube once it's been edited, so you can check it out again there if you have any questions. And thank you everyone for sticking with us.
Thank you.